So at this time, let me introduce Sonja Rivera Saenz, who's the Infection Control Director at Atrius Health, and she is going to present on infection control in the ambulatory setting during a pandemic. So Sonja, I will turn the floor over to you.
Thank you all, and good evening, everyone. Today, I will be presenting on infection control and ambulatory care, thinking about infection control as a field before the pandemic and impacts during the pandemic. To introduce myself, my name is Sonja Rivera Saenz, as Kevin mentioned, and I'm the Infection Control Director at Atrius Health. I want to start off with a little bit of a lens at what ambulatory care is, as well as what the organization I work for is. So in terms of infection control and where I work at Atrius Health, which is a purely very unique, especially in Massachusetts, it's an ambulatory care healthcare network consisting of 30 medical practice locations in Eastern Massachusetts. So some of the names that fall under that umbrella of Atrius Health include Harvard Vanguard Medical Associates, Granite Medical Group, Plymouth Medical Group, and Dedham Medical Associates. We have a wide variety of sites, so some of which pictured here are Kenmore, where that's almost resembling something like a hospital or an inpatient setting. Multiple floors, an endoscopy suite, an ENT suite, primary care. And then we have other sites that are relatively small and really are structured more like an office-based setting. So a mom and pop type provider's office. So think of all of our practice sites as being purely outpatient and ambulatory care. So all of the patient care at Atrius Health is performed on an outpatient basis. Our sites have multiple departments and specialties, poses different challenges. Some of those include internal medicine, pediatrics, urgent care. So that's where the highest volume in terms of suspect COVID patients or confirmed COVID patients have been seen at our sites in that urgent care department. Ears, nose, and throat, urology, endoscopy, surgical specialties, and OBGYN. So you can imagine with such a wide variety of departments in our outpatient sites, there's a lot of different things to look out for in terms of standardization, ensuring we're at the right standard when it comes to infection control. But this is a unique setting in which it's not tied to or affiliated specifically with a hospital or any inpatient setting. In terms of infection control as a background too, infection control, what our goal is preventing or stopping the spread of infections in healthcare settings, which we do in a multitude of different ways. So I lead the infection control team at Atrius Health. Operationally, I'm the infection control director. And what our team currently consists of is one medical director of infection control. That's my partner, Dr. Preeti Mehrotra. So she provides that clinical expertise for our team for infection control. She also has a great background in hospital epidemiology. And in addition to me, we have two infection preventionists, which is really great. And that really functions so that we're a central department. We're a consult for everything infection control related for Atrius Health. But we also need to make sure we have that site-based presence. So physically being on site, supporting staff, looking at the areas, providing expertise in that way. And it took a while for us to build to that way. For many years, it was myself and one other person in the infection control team, my manager previously. And we've actually expanded, which is great, from 2 staff, then we shifted to 1.5, and now we're to 3, which is really at a much better standard of what we need for infection control with so many outpatient sites. In terms of what are unique infection control challenges in ambulatory care, as you can imagine, there's a lot less literature, a lot less guidance, even public health guidance especially, or just scientific evidence that's really focused toward ambulatory care and outpatient care. When you see a lot of infection control articles, they're focused on the inpatient setting. One thing that's a little bit less studied is the staffing ratios for infection control and ambulatory care. A select few articles have been published and recommended 1 infection preventionist for every 10 outpatient sites. So that's something, there's not a lot of guidance again on that, really thinking about that, especially in inpatient settings that have a lot of affiliated off-site practices. That's additional very important work where you need to make sure that they're at the right standard they need to be. Some outpatient sites can be at a high risk for potential infection risk, specifically with sterilization of instruments, instrument reprocessing, where there needs to be a large focus there. We also have different regulatory agencies. So instead of the Joint Commission, we're DPH licensed. So we have an inspection by DPH every 2 years. And that is at some of our sites. So while some of our sites are DPH licensed, others are not or didn't have the requirement to be DPH licensed. So you can imagine that poses a different challenge where we actually need to make sure that all of our sites are at the right standard, but how they're physically created and laid out, and that poses challenges for infection control. So there are less standards and greater variability, which I'll show some pictures later, of the physical structure and space for outpatient medical sites. And there's a greater need to standardize infection control recommendations across variable practices. And that's really a common theme, particularly in outpatient care and ambulatory care and infection control, where it's very difficult to standardize because you have such different layouts, more of those mom and pop type office settings, in terms of very limited in terms of negative pressure rooms. Think of physical constructs that lead to infection control recommendations. And in terms of priorities before the COVID pandemic, I wanted to share a little bit before pandemic, what our focus was, and then how the pandemic has impacted us and what a lot of our work shifted to, and how infection control really, the field changed as a result of this pandemic. So before the COVID pandemic, our huge focus was cleaning, disinfection, and sterilization. So we had just come off of a very large project to really do a lot of audits of our areas where we have high level disinfection of scopes, for example, in endoscopy, ENT, and urology, which have a very robust, detailed manual process to high level disinfect. It can be very error prone, so it's very important to assess competencies with staff, make sure all of the guidance is up to date, and make sure that we're following best practices there outlined by Joint Commission, DPH, and other agencies. We always focus on transmission-based precautions and PPE, so that even before the pandemic was a large focus of ours. We get calls on anything from chickenpox to pertussis to suspect measles. We need to be able to identify that, provide the staff with guidance, and make sure they're wearing the recommended PPE, all based on how that disease is transmitted. And we did a lot of outbreak surveillance, which included pertussis, measles, mumps, rubella, varicella, active pulmonary TB. So these were some of those more common diseases before the pandemic. So for pertussis, we would actually get direct orders whenever a pertussis order was placed, so that we're aware of any potential positives in the future and can respond to provide the staff with guidance, make sure they're wearing the right PPE, do education, whatever is needed in that way. So based again on how that disease is transmitted, we follow up and we provide guidance for the staff and any next steps. We also did flu illness surveillance and prevention, provide some support related to employee health. We had a focus even before the pandemic on all hazards preparedness. So I ran exercises with staff and with leaders to really educate on, if there's a suspect or a positive measles patient at our site, how would we react to that? How would we make sure that we're identifying patients that were exposed immediately, making sure that they're vaccinated immediately. So like kind of all of the different steps related to infectious diseases and outbreaks before. And lastly, hand hygiene, running hand hygiene campaigns, supporting the staff with hand hygiene education is that single most preventative measure to prevent infections. And I put a blue here because our big focus for several months before the pandemic was that cleaning, disinfection, and sterilization. I want to show some pictures of our sites, but before that, just mention that we did a lot of auditing, feedback, development of all the standard work resources, specifically to make sure that staff are reprocessing instruments safely. So bringing it through, when that instrument is used on a patient, to the time it goes through an autoclave and is sterilized, to the time it's stored, all safely without any breakdowns. That being a large focus of ours in order to prevent any infections in our patients, make sure our staff are safe too with PPE during that process. So here's a few photos here. We have over 100 autoclaves across Atrius Health. So instead of any central sterile department or central processing department, we have everything is spread out. So think of that as a different unique challenge where autoclaves are within departments. Several autoclaves can be in a site where every department has ownership of that instrument processing workflow. These are some examples of pictures. So at the top, this is an example of something that we needed to change. So one thing coming in as our infection control team, we'd make sure that there's established dirty to clean workflows, meaning you're not going in an opposite direction or leading to cross-contamination. So the issue at the top picture here can see some point of care testing right to the right of a dirty sink. So this would pose an issue because instruments are being cleaned in that sink and they're going over a point of care testing area with specimens. And then there's a microscope, and then you're going to an autoclave. So we need to make sure that's completely shifted so that there is no potential contamination with specimens throughout that entire process, dirty to clean. So this looks like a completely different space at this point, but all of the patient care supplies were removed out of that dirty left side. And then all the point of care testing was removed completely from this area too. So to make sure that, again, developing workflows that are free of contamination, dirty to clean in one direction, and seeing as ambulatory care, these aren't two separate clean and dirty utility rooms. So that's something you'll see differently in the inpatient setting. So we work with what we have to make sure they're safe processes. In the bottom, this is a much better example here. This is actually a dirty to clean workflow for scope reprocessing that we provided some guidance on that goes in a counterclockwise direction. So they're appropriately cleaning that scope in the dirty sink, in the picture on the right, and then bringing it through those steps of that soaking process for manual high-level disinfection of scopes from right to left. Not autoclave is the left thing on the left. And another focus specific to infection control and the foundation for infection control is really transmission-based precautions. And COVID led to big changes in guidance for how we practice transmission-based precautions. We just had every new employee orientation prior to the pandemic. This is really the foundation for how we're guiding staff on how to protect themselves with PPE and how to approach a patient that's suspect for an infectious disease. And the main categories, even thinking before pandemic, are standard, contact, droplet, and airborne. Standard precautions are the precautions to use for every patient at all times, regardless of infectious status. So these are generally safe practices. And that includes hand hygiene, for example, cleaning and disinfecting after every patient encounter, as well as adding a gown and eye protection if splashes and sprays are anticipated, single-use equipment, so some of the general safety principles. Contact precautions are to use for diseases spread through, as it sounds, direct contact. So C. difficile would be an example of those, salmonella. A lot of the GI infections require contact precautions. So sometimes that soap and water with hand hygiene with soap and water instead of an alcohol-based hand rub, as well as that addition of a gown and eye protection being important as well. Droplet precautions, those are for the droplet transmitted diseases. Flu and pertussis are a good example of those. And that, think of before pandemic, the big intervention there was masking. So it was actually the staff wearing a surgical mask as well as the patient wearing a surgical mask. So again, this was before universal masking was a requirement in healthcare facilities. So that was the big change there that would actually prevent the illness from spreading, was a simple surgical mask for those diseases. And then airborne precautions require something different. So in our outpatient setting, we utilize HEPA filters. So where we don't have negative pressure rooms, we have a HEPA filter, actually increase the air changes in the room. The staff need to wear an N95 respirator. Patient remains isolated at all times. So the lab phlebotomist needs to come to the room. So that isolation is very important, and the patient has surgical masks as well. So you can imagine how much these have shifted so much in terms of how they're impacted by the pandemic. We have COVID, which really requires different precautions, making sure our staff wear N95s, also making sure patients that aren't even suspect for COVID, but are having aerosol generating procedures, that also requires an additional level of protection. So you have to do more for patients in general, getting aerosol generating procedures, as well as patients that are suspect for COVID. So it's that hybrid where you have that element of airborne, element of droplet. It's its own kind of category in a way. So when you think of standard precautions, how that was mainly hand hygiene before, as well as cleaning and disinfecting after every patient encounter. Now masking is just a part of all of these because we have universal masking in healthcare facilities. So this has led in some ways to like decreases in exposures to other diseases. Pertussis was really felt like it was eliminated or almost dropped down completely from our infection control radar because there wasn't any pertussis orders or suspect pertussis. Mumps, measles, those, it really actually prevents exposures because of some of the practices that are already in place. But it really restructured how we think of those. In terms of transmission of an infectious disease in a healthcare setting requires three different elements. So source, patients, healthcare personnel, household members, or community members being examples. Host, so is that host, you think of factors like are they immunocompromised, are you treating an underlying disease, and what's their immunization status? So for an MMR vaccine, that being quite effective after 2 doses, around 97% effective, we'd look at that if a patient is suspect for measles, if they shared space with them, right away we want to say, you know, are these people, are the staff have their measles documentation, or they have 2 MMRs, do they have a positive titer? That really puts them at a much less suspicion or much less risk of exposure. So that's really important to be considering. Then mode of transmission, again, we're taught in infection control on how different diseases are transmitted, and that's how we base the guidance we provide to staff to make sure they're protected. And in our field of infection control, we come from a few different backgrounds. So the main one being nursing. So nursing leads to a lot of infection preventionists. Another is the microbiology lab. So some people from the micro lab go into infection control. And third big category is MPH. So I'm from the Master's in Public Health background with epidemiology as my concentration. So those are kind of 3 large categories of different types of people and different educational backgrounds that go into infection control. And the big certification for us is the CIC, or the board certification in infection control. So in terms of during the COVID pandemic, we had that shift, which completely changed. So completely disrupted. I'm sure as many people experienced, the pandemic really impacted us in a large way. So our priorities changed to focus primarily on COVID-19. So thinking the other priorities taking the back burner in a way, we became fully that response team for COVID-19, and a lot of leadership from our team as well for COVID for the organization. So that became our number 1 priority. I want to get a little bit of a timeline. Some of you may recall some of these different points to kind of see how it's shifted so much in terms of reopening, in terms of PPE in the course of this pandemic. So at the beginning, February and March, I can recall very strongly when this was first identified in Wuhan City, China, and how it was called, you know, something completely different in terms of that novel coronavirus. It's really learning more about it. So we really let all the initial education. So once we got a solid case definition, once we learned more about where it was in the world, we really let all the organizational calls and communication on COVID-19 at the very beginning, then novel coronavirus 2019. We trained staff on PPE right away. So donning and doffing is something we need to do a refresher for with staff immediately. And then we were also the liaison between Atrius and Mass DPH for testing approval. It was a very different time in which a patient needed to have a very strict case definition in order to be tested for COVID-19. And it was very severe cases that required hospitalization at that time that would get approval from the state. So the capacity was very limited for testing, was not commercially available at this time. So our infection control team liaises and contacts DPH, seeks approval for testing, and it was a much bigger challenge at that time at the beginning. From March to June, our infection control team led the incident command team. So myself as incident commander, my other team members as different roles to really play a role in the emergency response of the organization. Provided guidance on the following. So created new infection control policies that were never there before. So universal masking, physical distancing policy, employee symptom screener. These are all different policies that need to be created. We had weekly educational written communications and calls with frontline staff where guidance changes all the time. That communication is so important to really reiterate new guidance, new messages, new documents, new triage workflows are created. So a lot of different guidance there. Drive-through testing. So our team's always been advocates for exposed and symptomatic patients being tested outdoors as an important administrative and engineering control to actually keep infection outside of the practice sites. So that's something we've strongly advocated for. So helped lead to some of the support for drive-through testing. PPE equipment for staff, making sure the site was equipped with all the N95 respirators they needed. There was big supply chain issues at the beginning. Huge struggle with surgical masks, think of N95 respirators where it was hard to get a lot of these supplies. So we need to make sure to look at different manufacturers and make sure staff had everything they needed. And we also established, this is very big endeavor, respiratory only sites, or really thinking of suspect COVID patients only sites and well care only sites. Some of our sites shut down to low volume and others were designated specifically COVID-19 only versus well care only at the beginning. So complete separation in that way. From June to August, we adapted to the Massachusetts reopening guidance for healthcare facilities. This is a time when we learned more, throughout those comments about the illness. And we reopened the sites that were previously closed. So that required a lot of walkthroughs, actually evaluating the space, because when you're opening a new site at this time during the pandemic, it needed to be structured completely differently. You needed to have markers on the floor for 6-foot distancing, all the chairs arranged for 6-foot distancing due to this illness, universal masking, staff PPE available at all the sites, and then also completely different symptom screening processes. So a greeter at the entrance of every site, assessing and asking patients and visitors for signs and symptoms and exposure history. So everything really, when opening that new site, became completely different. And then we took a look at how we can transition safely to mixed care. So a department or a site really providing care to both COVID and non-COVID related patients. So I was completely separated, it brought it more into a mixed care model so our sites could safely support both with the same principles of immediately isolating a patient suspect for COVID, applying transmission-based precautions and keeping them isolated. Then from August to December, that was when it got difficult because you got that second surge. In some ways it felt worse than the first surge with the numbers being so high and so many people getting sick at that time. And throughout this entire pandemic, our infection control team led the contact tracing specifically for Atrius Health in our workplace. So we would get all positive COVID results, both positive employees and positive patients during that second surge and during the entire pandemic. And we'd follow up to identify what exposures there were in our workplace. A lot of that could be due to breakdowns in PPE, for example, but to make sure that they were followed up on, informed, and if there were an employee that was exposed, for example, that they contacted the employee health department. So a lot of contact tracing there, which became even more stressed during that second surge. We did educational presentations and site visits to assess PPE compliance and precautions. Staff needed a lot of support specifically with such a pivot from completely separate designated sites to mixed care. So that was a lot of fear component, a lot of concern from staff. So we really had to go educate, really talk about the infection control principles, support them. That was a large undertaking at that time. And then it allowed us to get a little bit more back into our other priorities, including hand hygiene. We got into a campaign out to all of the sites to emphasize hand hygiene and provide them with giveaways, and getting back to cleaning, disinfection, and sterilization. So fortunately at that time, after several months with this pandemic, we were able to get back to some of our other priorities there, but very largely impacted. And then when it comes to January to May, so this kind of current state, we led the COVID vaccination effort at Atrius Health. So actually infection control played a role in setting up some of the vaccine clinics, talking to DPH and being that liaison, doing presentations on vaccination for both employees and then patients, which have been going on for the past 3 months. And then in that case, new challenges arose, including compliance with universal masking. Kind of new issues really came up just in terms of mask fatigue, in terms of what everyone was going through over this past year. So in a healthcare facility, that became very pronounced. there. So these are completely new challenges, while there's some really great news on the horizon in terms of just less COVID illness across the state and at our healthcare facility. So while the trends are going down, some of these issues still come up because it's still something long lasting that we'll be supporting as the pandemic, which will ebb and flow in terms of cases. The CDC guidance changes, pictured here, as many of you are aware, is also a big challenge. So with that mixed message and sometimes not knowing if somebody's fully vaccinated, saying that they no longer need to mask indoors or outdoors in most cases really posed a big challenge for our healthcare facility, as well as DPH or the state fully reopening as of May 29th. So these are things that cause different confusion, especially in the healthcare setting where we need to really clearly outline the requirement for universal masking, regardless of vaccination status. This posed a lot of big challenges in general. And in terms of infection control lessons learned from the pandemic, I just want to emphasize communication, particularly with frequently evolving guidance. So CDC guidance changing very quickly, Mass DPH guidance changing quickly, what we learned about this virus changing quickly, the variants. It led to so many iterations of different recommendations, guidance, and others where you have to really look at every communication avenue to share with staff. So we had global huddle calls, we called them, where staff could just call in and listen to that weekly update on COVID. We also had global communication, so that reached all staff at all times, but still you can get breakdowns in that way. So somebody not getting the message, so you have to also support with on-site presence, in general, site audits, site visits. And so focus on that communication was a very big lessons learned for us. We also need to ensure infection control guidance can be applied to a variety of settings. We have different structures and very different layouts. So when it comes to something like patient screening, which is very important to actually identify a patient suspect for COVID, you have to make sure that there's a streamlined way at every site to accomplish our staff immediately escort them directly into an exam room for care. And how do you communicate with the next department to make sure that they know to wear the recommended PPE, or that if it's a lab, that they come to the patient, so you keep them isolated. These are really important principles where that identification and immediate isolation can be challenging in different sites. So you have to make sure it's implementable everywhere there. And also identifying areas for donning and doffing. This was a lot of staff and providers could get confused on or just didn't have a good space within their department. So we'd go and visit, make sure we identify, a separate room available, that they could don easily, for example, and then everything they needed to dispose of the PPE in the way they needed. So with different layouts of the departments, you have to consider how to do that differently. And then also ensure recommendations can be sustained long-term during times of low patient volume and high patient volume. Some things were much easier when there were a lot of the non-essential procedures were not taking place, or just there weren't non-urgent visits taking place in healthcare, because it was a much quieter site. It was easier to implement some of these recommendations. But as sites get a lot busier, you potentially see a lot more suspect COVID patients because of a busier site, potential overlap with seasonal allergies and other illnesses, that some of these become very difficult for staff to implement, or they can get tired. It just takes a lot of stress on the workforce to actually have them go long-term. So that's been a challenge, I'd say, as well. And overall, I think that wraps up my presentation today, and I'm happy to answer any questions on any of the content.